Welcome to the PIMA Council on Aging, Understanding Medicare for 2023. This is going to be a 2-hour presentation that you can watch at your leisure. Our presenters today are Penny Plant, who will begin the presentation, and the second half will be Vicky Spritz, and I am Linda Kumalo, the PIMA Council on Aging Program Coordinator. So without wasting time, we'll let Penny go ahead and start.
Okay. Welcome. My name is Penny Plant, and we're happy to have you here today to listen to our presentation. Before we get started, the Area Agency on Aging serving all of Pima County, that's us, PCOA, and you'll see the helpline number, that's the general helpline number, and then you can also email that helpline, and they can help you out, get you going on where you need to go. If it's specific to Medicare counseling, please note the number there. And then there's also an email address that you can send your questions to. We are volunteers that respond to these questions, so please bear with us as we return your phone call, and we'll get to you within the day. Generally, during open enrollment, it might be a little longer. The nice thing about when we do come and talk to you is that PCOA neither sells or endorses any Medicare plans. Our goal is just to educate you so that you can make the best decision that fits your needs. If you like what you're hearing here and you want to help, we are always looking for volunteers. So if you are interested in being a volunteer for the SHIP program or for PCOA in general, please contact Mary Donahue, and there's her contact information at the bottom of the screen. So for today, what we're going to do is cover 4 areas. Explain the basics. We're going to talk about how to enroll, what happens and how you make changes once you've enrolled, and then some Medicare hot topics, just some things to be aware of as a Medicare recipient. We're going to start with the Medicare Basics. I like to look at this first section as laying the foundation. So what we're going to do is do a lot of work on explaining Medicare and going from there. Medicare starts generally at age 65. The other opportunity, or one of the other big opportunities, is if you are under Social Security disability, after 24 months, you become Medicare eligible. And then you can see there's some other reasons why you might have Medicare eligibility. Medicare is managed by the Centers of Medicare and Medicaid Services, or CMS, and you must be a U.S. citizen or be lawfully present in the United States in order to enroll for Medicare. So this slide we'll keep coming back to at various different parts of the presentation, but one of the things I want to emphasize is that double line down the center. Look at this kind of like a two-way street. On the left-hand side is Original Medicare, and on the right-hand side is Medicare Advantage. You don't cross the double line. You can't mix and match these, and we'll talk about why. So your Medicare choices, I also look at this as a history lesson as far as how Medicare evolved and some of the choices we have today. In 1965, Medicare came about, and it's Part A, hospital insurance, and Part B, medical insurance. And it's called Original Medicare. So Part A covers your inpatient services, such as hospitalization at a hospital or religious non-medical healthcare institute, rehab and skilled nursing facility, and just an emphasis on there is no long-term care under Medicare, whether it's Part A or B. And there's also inpatient hospice care. Part B, which is what most of us use, is for all of your other services, including observation status in a hospital. And we'll talk about that towards the very end as what that means. But it's mostly your doctor services, outpatient care, preventive services, diagnostic lab and x-ray therapies, whether that's occupational, physical, or speech therapy. Durable medical equipment, so if you need the wheelchair, the walker, or the bed, hospital bed, that falls under those categories. Emergency and urgent care, and ambulance to the nearest hospital, not to the hospital of choice if it's further. Home health care may fall under either Part A or B. what Part A and B does not cover is prescription drugs, which is your pharmacy, outpatient. So when you go to like your Fry's or Costco or CVS, wherever you go to get your prescription drugs, or if you do mail order. Dental care and dentures, except for limited situations on dental care, and we'll talk briefly a little later. Hearing aids and eyeglasses, cosmetic surgery, alternative care, except if there is a little provision for acupuncture, for lower back pain. Naturopaths are not covered. Custodial and long-term care, and international travel, including cruise ships. So if you hadn't thought about that, once you leave the U.S. border on the ocean, you're no longer covered by Medicare. Your original Medicare 2023 Part A costs, we're going to start with, like I say, Part A. For most people, that premium is $0. And the reason is that during your working career, you always had that tax coming out of your paycheck. But in order to take advantage of that, you have to, at no cost to you, you have to have 40 credits, working credits. And so 4 credits a year, or 4 quarters a year, so that's 10 years. If you have less than that, you can see that you will have some payment depending upon where you're at in the number of credits. So if it's 30 to 39 for 2023, it's $278 you need to pay. And if it's less than 30, it's $506. There is an earnings caveat or earnings criteria, and that's $1,640 in each quarter is equal to 1 credit. You actually can accrue that quicker, but you only get 4 credits a year. So they spread them out over the year. Inpatient hospital, your deductible is $1,600 per benefit period. And that benefit period can be a little confusing, but a new benefit period starts when you have not received inpatient services for 60 days in a row. So an example would be, so perhaps you had a really severe accident in January and you were in the hospital for several days. And you leave in the hospital, say January 15th. And then March 1st, you're back in the hospital for appendicitis, perhaps. Because it's within the 60-day period, so you got out February or January 15th, but this is now, March 1st that you're coming in, it's less than 60 days. You do not have to pay that $1,600 again. Now, if it was March 31st, that would be a different story. You would have to pay that $1,600. For the next 60 days, once you're admitted, or for those first 60 days, it's $0 copay per day. You go 61 to 90 days, it's $400 per day copay. And if you go beyond the 90 days, it's $800 copay per day. And there is a 60-day lifetime limit on all of that. Most of us, very few people will ever get to that. But if you do hit that, you'll know it. So you do have a lot of out-of-pocket expense. Skilled nursing or rehab facility, after 3-day hospital inpatient stay, you do have some coverage. And when we say 3-day hospital inpatient stay, that's 3 overnights. The copay for the first 20 days is $0. 21 to 100 days is $200 per day. And after that, you pay the full cost. Hospice, limited cost for pain meds and up to 5% for inpatient respite care, does not cover room and board. So keep that in mind. Original Medicare does not have out-of-pocket limits, and you're going to hear us say that quite often during the presentation, and that's why we're looking to see how best we can mitigate your out-of-pocket expense. Your original Medicare 2023 Part B costs, B as in boy, the premium for 2023 is $164.90 per month for most beneficiaries. If for some reason, and many of us have, if you're still working, 2 years, if you were working in 2021, more than likely your adjusted gross income, if you had a high paying job, was enough that it might throw you into having what we call an adjusted gross income of greater than $97,000 for an individual or $194,000 for a married person. And that can cause some issues. We call it the income related monthly adjustment amount, or IRMA, and we'll talk about that on the next slide. The annual deductible for Part B is $226. The coinsurance generally is 20% of the Medicare approved amount, and there's no charge for many of the preventative services. And again, original Medicare does not have out-of-pocket limits. So let's take a quick peek at the IRMA and how that might affect you. This is the chart that you may want to refer back to. And a lot of people don't realize this until they get hit with it after they retire or they start drawing Medicare. For a person that individual with $97,000 or less of a gross income, adjusted gross income, they're not going to pay any more than the $164.90 for 2023. But if they had an income of, let's go a couple lines down, of say $150,000, they're going to pay $329.70. So there is an upcharge based on your income. And it is from 2 years ago. Now, you can always, if you have quit working, you're retired, maybe you retired 1 year ago and now you're Medicare, you can apply to have this waived, but and you'll see the form number down there at the bottom of the slide. No guarantees that they will agree to waive that for you for the next year or so, but you have that opportunity to apply for it. And you also need to know that it is a rolling 2 years. So for 2024, it'll be based on your 2022 income. So it just moves with you. So we're back to our chart here. In 1980, remember we've said that there are no out-of-pocket limits as far as what you can pay if you have a large loss situation. In 1980, supplemental insurance came on the scene, and that helped mitigate some of that out-of-pocket expense. So we'll talk about that. But there's different types of supplemental coverage. A lot of us immediately think of Medicare supplements or Medigap plans. They're one and the same. But each person needs to have their own plan. There is no such thing as a group Medigap plan where a husband and wife can join in the same plan. But there's also other alternatives to supplemental coverage. If you have these available, you're very fortunate. There's retiree health benefits. So you may be military, could be TRICARE for Life or CHAMP VA. The federal program, FEHB, some employer or union plans, or you may be part of a state program such as AZARS or ADOZ. Or if you're low income, you could be dual eligible and have Medicare and Medicaid. So we'll talk about the lower income briefly in a few slides. What we're going to focus on, though, are those individual plans that you would purchase on the open market. So it'd be Medigap or supplemental insurance plans. The nice thing about these plans, depending upon which one you choose, they'll pay some of your Part A and B costs, or maybe they'll pay all of them, depending upon where you're at and when you retire and when you turn 65. In order to have one of those plans, though, you must enroll in Original Medicare. That means you have to have Part A and B. And when you do choose a policy and you get the policy in front of you, it needs to say Medicare Supplement Insurance. There are 8 plans that are standardized by the federal law. I call it alphabet soup: A, B, D, G, K, L, M, and N. And some of the plans with the same letter all the plans with the same letter offer the standard benefits. So for example, we use Plan G because that's the most popular now. A Plan G is a Plan G. It doesn't matter if it's Mutual of Omaha, Aetna, Blue Cross, Humana. They all offer the same benefits. Now, what may differ between companies is that the companies may add some benefits to it, such as discount programs for gym, vision, dental, hearing. They may have some other programs available for you as well. That's at their choosing. That's not part of the standardized program that's regulated by federal law. In Arizona, Medigap is not sold to individuals under 65. So if you had one, you're grandfathered in. If you haven't turned 65 yet when you're on disability, then at 65, you will have an opportunity to look at one of these programs, and we'll talk a little bit later about those opportunities. This chart gives just on a high level the differences between the various plans. So if you look across the top, you'll have plan type, Medigap plans, and this is based on 2023 information. And then you'll see the letters above. And above those letters, you'll see an average premium based on the latest information that we have. And that's an annual premium. And it is based on a person that's age 65 and non-smoker. So just kind of keep that in mind as well. This just gives you a ballpark. Above G, you'll see a little line there, or a little premium of $474 on average, and it says HD. That's for the Plan G high deductible plan. So let's talk a little bit about how to read this chart to make the best use of it for yourself. If you're really wanting something that's going to cover almost everything, then you're going to want to take a look, start looking at the columns, the column on the left that says plan type. Exactly, you know, what is it that plan A? So for example, the plan A deductible, you go across, and what you'll see is that the Medigap plan A does not cover the Part A deductible. Plan L only covers 75% of that, but you'll see that B, D, and G and N cover it at 100%. So that's just kind of a way to give you a guide for how to read this. If you go down to Part B, you'll see that none of them pay the Part B deductible. So you will be responsible for paying that regardless of which plan you choose. When you get back into the coinsurance, you'll see that the various plans will cover that at various levels. They'll either cover it at nothing as far as hospitalization goes, or maybe 50% or 75%. And there's 4 plans that will cover it at 100%. When you get down to the Part B coinsurance at 20% that you need, that Medicare says you would owe, you'll see that most of the plans will pay for it at 100% once you get through the deductible. The one thing I want to draw your attention to is if you're going to travel outside of the United States, that only Plan D, G, and M and N have any kind of foreign travel benefit. And it is for urgent emergent care, and there are limitations. If you are interested in the Plan G high deductible plan, just be aware that you have to pay the first $2,700 out of your pocket. That's after Medicare pays their part. And then the high deductible plan will kick in and pay at 100%. So here's a different way of looking at Part B that we really want to emphasize. You need to know that there are 2 different types of providers. The opt-out one, and I'm going to address that first, is really if a provider has opted out, that means they don't accept Medicare and you're on the hook for the whole bill. So I'm only going to focus on participating and non-participating. Participating providers agree to accept Medicare's assigned amount. So in this example, the doctor charges $100 and Medicare pays 80%. All of the plans, whether it's A, F, G, M, or whatever, the plan will pick up the 20% and you pay 0. So if you have a Medicare supplement and you go to the doctor, you pay your deductible first, which and then Medicare pays their amount of $80. Say you've already blown through your deductible, they pay $80, you pay $20, but if you have a Medicare supplement, they'll pick that up for you. If you have a non-participating provider, those are providers that can charge a little bit more. They'll agree to take Medicare, but they have an arrangement with Medicare that they can charge up to 15% more. So in this case, the doctor's charging $115. Medicare still says it's only worth $80. And you'll see all the plans there, the A, B, C, D, and M, that won't pick up that excess charge. So you are responsible for the $15 difference. If you have an F and a G, those 2 plans will pick up that excess charge and you won't have an out-of-pocket. Plans K, L, and M, they have the variances on the deductibles and the co-insurances and that type of thing. So you have to look at their payment schedule. We really do like to give people some assistance in asking questions when you're looking at Medicare, Medigap plans. You want to know how long they've been in the market, what's their rating, and there's an AM Best rating, there's a standard rating. In the date that you contacted the particular Medigap plan. You want to know what the premium is for your age, because it can be affected by how old you are at the time you're purchasing the plan, your gender, smoker status, and that type of thing. So you're going to want to know if there's any premium discounts, including if you're a non-smoker, if you live with someone in the household. You also want to know about the enrollment discount. So several plans will ask you, several companies, I should say, will ask you, if you're newly enrolled, we'll offer you a new enrollment discount. And that means you're enrolling when you first become eligible for Medicare Part B. But you need to ask the question, how long does that discount last and how often does it decrease? And what does that decrease over each year? We just don't want you to be surprised. We want you to understand what that is. The other thing that you want to talk to them about is premium history over the last 5 years. Do they have a history of pretty level premium increases or maybe very minimal, or do they spike up and down? You want to know that. Crossover billing, I think most of them anymore comply with that. But what that means to you is that when you go to the doctor's office and you present your Medicare card and your Medicare supplement card, the doctor's office will put that information on of your Medicare supplement on the billing to Medicare, and then they will automatically, Medicare being they, will automatically send the balance of the bill over to your provider. So you're out of the claims processing business, which is really nice. If you are not in your guarantee issue period and you have a pre-existing condition, you'll want to know if the plan will accept your condition. So you need to talk to them about that. And even if you are in your guaranteed issue period, which we'll explain a little later, if you're not currently covered by an insurance plan, there may be a waiting period for a pre-existing condition. So you'll want to know about that and what that means to you. So we're going to jump over the double line and go over to Medicare Advantage plans. And these came into effect in 1997. And this is just another way to get your Medicare. What the Medicare Advantage plan providers did is came to CMS and said, we think we can help you save some money on Medicare. So if you let us manage Medicare Part A and B on your behalf, we'll wrap benefits around that and submit one complete package for people to purchase. As a result, claims don't go directly to Medicare. When you use services, it actually goes to the Medicare Advantage plan and they process all those claims. You still have all the Medicare rights and protections, just as if you were under original Medicare, because technically you have Medicare still, Parts A and B. But they offer extras, vision and dental, and it can vary by plan. Not all plans are created equal when they offer those extras. So you just need to be aware and really choose the plan that's going to best fit your need first as far as medical care, and then take a look at the extras. That's kind of the way we look at it. You are choosing to receive your Part A and B benefits through the private insurance company. So just kind of repeating what I've said. You use the plan's ID card. So your provider may also ask to see your Medicare card for certain situations. But in general, you have one plan or one ID card that fits all. So you go to the doctor's office, you present that one card. When you go to the pharmacy, you present that one card, and that takes care of it all. You should not be enrolled in a Medigap plan. There's no advantage to it, and they don't play well in the sandbox together. So please don't do that. So as of 2021, ESRD beneficiaries may now roll in a Medicare Advantage plan. So we're happy for those folks that may need that additional coverage. And so now you can take advantage of that. There are several types of Medicare Advantage plans. Sometimes you'll hear them referred to as Part C, but the most prevalent one that people use today is the HMO. And if you're used to HMOs, you know that they are a managed plan. You have a primary care physician, and you often have to get a referral from that primary care before you can go see somebody else. So it's always been referred to as a gatekeeper. The network is going to be smaller. And just kind of a note on networks, most of the networks are restricted to Pima County. Depending upon the insurance company you choose, they may have some options outside of Pima County under certain circumstances. But for the most part, your providers are restricted to Pima County. Emergencies covered out of the network, but follow-up care may not be covered. And so you need to let your plan know immediately if you have an emergency situation. PPO, most of us, I think, in the workplace are somewhat familiar with the PPO. It's Preferred Provider Organization. Again, it's a network of providers. It's going to be a little bigger network. And they actually do give you some options to go outside of the network in certain situations. You usually pay less if you do use a network provider, and you will pay more if you go outside the network. You can see any Medicare provider outside the network who is accepting new patients. And generally speaking, you don't need referrals for a specialist, meaning you don't have to get permission from your primary care provider. But keep in mind that some specialists still require for you to have a referral. The hybrid that's come up is now called HMO point of service. So it's a health maintenance organization with a point of service, which gives you a little more flexibility in going outside of the network. You still have the HMO component where you have a primary care, and typically you're going to have the primary care refer you to a specialist, but there are certain situations where you may be able to self-refer. Again, you need to take a look at all of their provisions in there and really understand how the benefits work. The last type of plan is a medical savings account, very similar to a health savings account if you're familiar with those from your working career, or a flexible spending account in some limited basis. It has a higher deductible. There are two plans available here in Pima County. The deductibles are $5,000 and $8,000. Depending upon which plan you choose, the program will put in either $2,000 or $3,000 into a special savings account for you. But the caveat is two things. You have to use a Medicare participating provider. Not a non-participating provider does not have to agree to treat you. And you have to satisfy the full deductible before the plan pays. That's why you want that side fund to help pay for some of the little stuff. That account does roll with you every year, so it is yours to keep. So whether it's the $2,000 or $3,000, so you can build or bank a bit of money to help you through the hard times. Some providers will not accept Medicare Advantage members, even if the member wants to pay for it out of pocket. So we'll talk about that over here. The two kinds of Medicare providers under a Medicare Advantage plan are Medicare providers accepting Medicare and agree to accept Medicare's assigned amount. And I'll go one step further in saying that they are also participating providers with whichever plan you choose, and they've agreed to the terms and conditions of that plan. Non-participating providers accept Medicare, but may charge more than Medicare's assigned amount. If you remember that from that 15% surcharge. The problem is that non-participating providers don't have to accept Medicare Advantage plans, again, even if the member wants to pay out of pocket. And the example we use quite often is Mayo Clinic up in Phoenix, Scottsdale area. Mayo Clinic does not accept Medicare Advantage participants. So you need to be aware of that. And if that's really important to you, then you may need to consider a Medicare supplement. Your 2023 Medicare Advantage costs and this is what's really attractive to a lot of people when we get down to the plan premiums themselves. You still have the Part A and Part A premium of $0 for most people. If you had your 40 credits, or your spouse had the 40 credits and you're getting your benefits under them. Your Part B premium is still going to be $164 per month. Your Part C premium, depending upon which plan you choose, can be anywhere from $0 to $118 a month. And there are a number of plans here in Pima County that have $0 cost per month, but you pay for it in different ways. So we'll talk about that. Oh, and one thing, there may be a separate deductible for Part B drugs under that program, so you want to take a look at that as well. But how you're going to make up for that, we call it, pay at point of service, is that there are co-pays involved, and there could be some co-insurances involved when you receive the services. There's a number of plans that don't charge you anything for your primary care services, but there are a number of plans that do have some kind of surcharge or a copay up to $35. Specialists, the same thing. It can be $0 to $80 depending upon the plan. Your ambulance, $100 to $480, and then 20 to 40% after that. Inpatient stay, $100 to $450 per day for the first 5 to 7 days. Again, it varies by plan. Chemotherapy medication is going to be 20% coinsurance. Durable medical equipment is going to be 20% coinsurance. And the plans do cap your out-of-pocket expenses. But again, it's a range depending upon the plan. It can be anywhere from $2,499 for the year to $11,300. So you can see you really need to understand what you're purchasing before you jump in and sign on the dotted line. It excludes Part D and extra benefit costs. As far as the costs shown here. Your Medicare Choices. Now, we show this on both sides of the fence, if you will, because Medicare Part D prescription drugs didn't come into the scene until 2006. And everybody was very happy about that because that's the first time outpatient prescription drugs has been covered for older adults. If you're on original Medicare, you will need to purchase a standalone Part D plan. You can enroll in either Part A or Part B. You don't have to have both. And each plan has a formulary. So if you're used to being insured by either the healthcare exchange or your employer plan, you're familiar with formularies. The providers will cover certain prescriptions at a certain level and that type of thing. That's no different than what it is here. But you do need to understand their formulary because they don't have to cover every single drug that's out there. You may pay the full price if your drug is not on the formulary or if you use a non-network pharmacy. With original Medicare, you have to have a standalone drug plan in order to get that. And Medicare does not pick up, Medigap plans does not pick up the Part D charges. With Medicare Advantage plans, if you do decide to go with the MSA, you would have to participate in a standalone Part D plan. So you would have to buy that. With most of the HMOs and PPOs offered within Pima County, they all include Part D, except for 5 PPOs and 1 HMO. So let's talk a little bit about Part D. If you're purchasing it because you have an original Medicare Part A and B plan, or you're on an MSA, the cost range per month is $5.40 all the way up to $166.20 per month. With HMOs and PPOs, for the most part, it is included in your Part C plan premium. And there could be an additional Part D premium if you're subject to the IRMA. In other words, you had a high income 2 years prior to your enrolling in Medicare. The annual deductible is a wide range as well. It goes anywhere from $0 to $505 for 2023. Typically speaking, Most plans don't charge a deductible if it's a tier 1 drug, which is your preferred generic drugs, but it goes from there. All the plans vary widely as how they apply the deductible. Once you and your plan have spent $4,660 combined, in other words, the plan paid their share, you paid your share, then you will pay no more than 25% of the cost for the prescription drugs until the out-of-pocket spending is $7,400. That's out of your pocket. That's been known as the donut hole, and I think people still refer to it, but there technically isn't a donut hole any longer. That's just, if you have a huge amount of drugs, just be aware that you may end up into this space where you have to pay 25% of the cost. Once you come out of that, then the plan will automatically put you into the catastrophic coverage, and you'll pay no more than 5% of the cost of the prescription drugs for the rest of the year. Most of us are never going to get there, but some people do, and some people get there pretty fast. So just be aware of your situation and how your plan will apply in all of these cost categories. Part D does not have out-of-pocket limits. So there's that little caveat again of out-of-pocket limits. The best way to find your plan, whether you're doing a standalone Part D plan or you're doing it through a Medicare Advantage plan, is to go through Plan Finder. And we help people with this all the time, but you can do it yourself. And what you do is go to medicare.gov, and you'll come to a landing page that looks similar to this. Sometimes they change the picture up. And what you want to do is click on that little tab that said, well, it's a little box that says Find Health and Drug Plans. And they'll take you through a list of questions, and then you can answer that. If you want to get it personalized, in other words, you want to make sure that those drugs stay in there, sign up for a Medicare.gov account or my Medicare.gov account. And then when you log in, all the drugs that you have been using or that you've input in the past will still be there. You do have to have a Medicare card number in order to do that, because it needs to know your Medicare number, and it also needs to know your Medicare effective date. But you can visit the site and do this if you're just getting into your Medicare eligibility. It's a really cool tool, especially during open enrollment, and we really encourage people to use this during open enrollment because plans do change every year. Some tips for saving money. You probably know a lot of these already, but if you don't, here's a few options. If your medication is in a high tier, you can always ask your plan for a tiering exception. You can ask your doctor for samples, but you know, they can only give you so many. If your medication is not on the plan's formulary, you can always ask the plan for a formulary exception. And if you're going to do that, the doctor will have to help you with that, because they're going to go through and say, well, the reason why we're asking for that exception is X. So there is going to be some paperwork involved. You can ask your pharmacist or doctor if there are generics or other medications on the plan's formulary that you can take. Some other options is to compare plan coverages during open and special enrollment periods. Again, using Plan Finder, wonderful tool. Mail order is sometimes, but not always, least expensive. Costs are usually lowest if you use the plan's preferred pharmacies, followed by network pharmacies. And of course, then you're going to pay the full cost if you're out of network. So, for example, probably the easiest way to explain this, if you use CVS and the plan that you're looking at says that Walgreens is a preferred pharmacy, you need to check to see if CVS is a network pharmacy or preferred. More than likely, it will be a network pharmacy, which means that if you go to Walgreens under that particular plan, you'll have a better cost to you. And if you go to CVS, you're going to pay a little bit more. Now, if you go to a pharmacy that's not even on that list, you're going to pay the whole cost. Compare the cash price with your Part D copay. Oftentimes, well, I won't say oftentimes, but depending upon the drug, believe it or not, paying cash will be least expensive to you versus using your plan. You can also use GoodRx I think they've got a huge presence anymore in that market. There are other plans, discount plans out there, including Needy Meds if you're low income. Speaking of low income, help with Medicare costs. There is a Medicare savings program that will help low income beneficiaries pay for their Part B premium. And if they also qualify, it will help them with a supplement. Basically, they'll become dual eligible and be eligible to enroll in both Medicare and Access, which is Arizona's version of Medicaid. So these are the three categories: a QuinB or qualified Medicare beneficiary. That is the for the person with the least amount of monthly income, whether it's a single person or a couple. They will pay your Part A and B premiums, deductibles, and copays. The next category is specified low-income Medicare beneficiary. It pays your Part B premium only, and it will also entitle you to full LIS or extra benefits for our Part D, which is really helpful. And then there's the QI program or qualified individual program, which is just the next step up. We don't have the information here because it does change every year. But if you're curious about that, please call us at PCOA on the Medicare information side, and we will be happy to help you with that. Or you can request, if you're a handout from us, if you can request that through the email address. My last slide on this presentation, while Arizona Long-Term Care System or all-tax is not part of Medicare, we want people to know about this because it does impact people's health care. So there is a program through Access that will provide long-term care in assisted living facilities, nursing homes, and provides in-home care for individuals who would otherwise be institutionalized. And it is a very complex program. PCOA offers classes on that, so we do encourage you to find out a little bit more. If you have someone, or if you or a loved one really should be in a nursing home but can't afford it, there may be some ways for it to be covered under the Access program. And our people here can help you at least get started with that, and attending a class would be a great start. With that, we're going to transition. Take a short break, stand up, move around, write down any questions you have, so that at the end of the presentation, you can call us with your questions, and or try and figure out the best way to get the answer. But we're happy to help you in any way we can. And with that, Vicki will take over the second half. And she's going to give you all the real good details.
We'll see. We'll see. All right. Okay. Thanks. So you are listening to this and thinking many of you may be newly 65 or approaching 65 and trying to figure out what factors are important to you in making this choice about how to get your Medicare benefits. One issue has to do with your access to providers. How do you feel about needing to get a referral from a HMO primary care provider to see a specialist? For some people, that's not a big deal. They're used to doing that. But for others, that they may not like doing that, and they may not want to have to get referrals. The issue of provider choice is very important. Remember that the Advantage plans are networked, primarily here in Pima County. Each county has their own. But for some people, being able to choose their own doctor and hospital is very important. Or you might be able to find that the doctors you want to use and the hospital you want to use is in an Advantage plan that you're interested in. So you want to think about that and be sure you understand what your options are. Again, because these are geographically based, the Advantage plans tend to not have access to specialists outside of Pima County, whereas someone who has original Medicare with a Medigap may be able to go anywhere if they heard that there was someone who really understood a particular condition somewhere else. The issue of access to providers who do not take assignment, or those non-participating providers. As Penny mentioned, the Mayo Clinic up in Scottsdale is one that will not see Advantage Plan members, whereas people who are on original Medicare with a Medigap would be able to go there. And the other big issue for people is about how much they're going to be in Pima County and how much they're going to be traveling. If you are someone who maybe only travels once or twice a year to go see family, but you are mostly here, then you might be fine having an Advantage plan that is geographically based in Pima County. But if you are someone who is planning to hit the road as soon as you turn 65 and only visit here occasionally, you may find that original Medicare with a Medigap would work better than an Advantage plan. When we talk about the health concerns, how much are you using medical services now? And what's your family's medical history? In a certain sense, if one goes with original Medicare and that Medigap, they are paying a premium, and then all the services that Medicare would approve that fall into those categories that Medicare covers would be covered, even if you had a lot of needs for medical services. Whereas with the Advantage plans, you are paying when you use services. So people have to think about how that is going to impact them. Remember, as Penny said, if you are under 65, you cannot get a Medigap here in Arizona, but when you turn 65, that right comes back to you. The other issue, again, has to do with medications. Using that plan finder can help you find out which plan, whether we're talking about standalone Part D or within an Advantage plan, which is going to cover your medications the best, be most cost effective. Those extra benefits that can be included with some of the Advantage plans are wonderful, and we're glad for people to have access to that. But it's really important to know whether a particular Advantage plan is going to work well for you on medical services before you get excited by the dental visit or the eye check, because those are pretty limited benefits. So again, when you look at this big choice, you see that people get their Medicare in a number of different ways. Some people go with original Medicare and they get a Medigap and they get a standalone drug plan. Other people go with that MSA and get a standalone drug plan. Other people sign up for an Advantage plan, either an HMO or a PPO. Some people may be eligible for a retirement plan. So again, they would have Medicare and then the retiree plan that they are entitled to would in some form supplement that. Other people, because they are lower income, become eligible for access, and they would have Medicare and access. And as we say on the TV, you will probably see a lot of commercials that say you may not be getting all the Medicare benefits you're entitled to. The problem is they do not tell you on those commercials what things are going to cost you and what is going to work best for you. We try and listen to people to be sure that we understand what they need in their Medicare benefits. When you look at this, you can see with this big choice, when you look at original Medicare, there's the Part B premium, there's a Part D premium, there's a Medigap premium, which has a big range depending on which one you pick. But then while there are no out-of-pocket limits, that Medigap is paying all or some of those copays, coinsurance, and deductibles, so that the out-of-pocket costs, other than the premium and the copays on drugs, are fairly low. What you can see is that when someone is on original Medicare, they are entitled to see any Medicare provider anywhere in the United States who accepts Medicare and is accepting new patients. And they get a little bit with their Medigap for foreign travel and maybe some extra benefits. With that MSA, again, paying that Part B premium, the plan is going to deposit $2,000 or $3,000 into an account, but the person has a $5,000 or $8,000 deductible. It's a little harder for us to say how much this is going to cost because one person in the MSA may use very little of their of that deposit and have that roll over, whereas somebody else uses all of it and may still have to spend money to reach that deductible. After the deductible is reached with that, again, then the plan pays everything. And with the HMO or PPO Advantage plans, people are still paying that premium for the Part B, but then they have copays and coinsurance up to that out-of-pocket limit. And again, some people who are in Advantage plans are using a lot of medical services and might come up to that out-of-pocket max, where somebody else might not. What's also hard when you look at this is knowing that there are a lot of Medigaps available, a lot of Advantage plans available, a lot of standalone drug plans. One thing we have here at PCOA is we have spreadsheets so that you can look and compare different Advantage plans or look and compare the cost of different drug plans and Medigap plans. So we have more information that you can get from us to make these decisions. When looking at Advantage plans, the two biggest things have to do with the network and the prescriptions. How large is that network? Are the providers that you want to use in that network? One thing I say is that for people who have already been here in Pima County for a while, if you have some doctors or labs or a hospital that you want to continue with, you might want to reach out to them and find out which Advantage plans they participate in, because it's not going to do you any good if you can't get to the doctors that you want to see. With the prescriptions, you want to know how the costs, how those drugs, if they are included in the formulary, and how much they're going to cost you. You also want to know if your plan contracts with any providers outside of the home service area, what else, and what they would consider emergencies if you were outside the service area. You want to know about the extra services. You want to know about any costs. And there are, on the spreadsheets that we have about these Advantage plans, there are ratings, a star quality, and it's on a 5-star rating, and you can look and be able to compare that way as well. There are also some Advantage plans that are special for certain specific groups. One has to do with people with chronic needs, people who have COPD, diabetes, heart care, end-stage renal disease. Now, it does not mean that someone who has that condition must go into that plan, but they might find that that plan is attempting to offer some additional benefits so that they might find that it works well for them. There are also some plans that are special for people who live in nursing homes because they go and visit those nursing homes. And people might find that easier than having to leave to go to the doctor. And again, no one has to sign up for that, but they might want to. There are also 3 plans that are available for the people who are dual eligible on Medicare and Access. And here, again, people don't have to sign up for those plans, but they may want to, because those plans then align very well with Access plans, and those people can then be sure that the providers they see, if they are in those plans, are going to be covered by both that Advantage plan and by Access. Okay, so now we want to talk about how to enroll in Medicare. And first thing is, you see that we have the Social Security website listed because people do sign up for Medicare at Social Security. And we have the national phone number and the local phone numbers as well. If someone has retired from the railroad, they do all this with the Railroad Retirement Board. Everything, as we say, starts with A and B, and that is the part that one signs up for. And it's when one has signed up for A and B, or A or B, that one might be able to add other services. Now, there are some people who do not have to do anything because they are going to be automatically enrolled in Part A and B. And those are people who have been receiving Social Security or Railroad Retirement Board benefits for at least 4 months before their 65th birthday, as well as people who have been on Social Security disability for 2 years. What happens then is that the card comes in the mail. And one thing that is very important is knowing if Social Security has your correct address, because you don't want your Medicare card going where you lived last year. So the card comes in the mail. There is an opportunity to delay Part B, and we'll talk about that in a couple slides. But you must enroll no later than 3 months after the Medicare effective date in either a drug plan or an Advantage plan. Now, some people are not taking Social Security before they turn 65. Either they're waiting for their full retirement, or maybe they're even trying to make it to 70. So if you are not automatically enrolled, you get an initial enrollment period for Parts A and Part B. And that initial enrollment period is 7 months long. It's the 3 months before your birthday month, the month you turn 65, and the 3 months after. If you enroll during those first 3 months before your birthday, your Medicare effective date is going to be on the first day of the month that you turn 65. If you wait until those last months to enroll, the Part B will start on the first of the next month. And you can enroll in an Advantage plan or a drug plan during the same 7-month period. Now, Medicare does a little goofy thing if your birthday is on the first of the month, because then you have the 4 months before your birthday month and only 2 months after the month you turned 65. So if my birthday was July 1st, I could enroll on March 1st, and my Medicare would start on June 1st. And we have no idea why Medicare did this, but this is the way it is. Okay, so now you've gotten yourself enrolled in Original Medicare, and you're looking at Advantage plans and drug plans. You can enroll through 1-800-Medicare or use the Plan Finder. So if you use the Plan Finder to find the most cost-effective drug plan or Advantage plan, there will be a button which allows you to continue enrolling, and then that company will send you paperwork afterwards. You can also contact the plan directly, and from our spreadsheets you can get contact numbers, or you could use an agent or broker. If you use an agent or broker, they are not charging you. They get compensated through the plans. To enroll in an Advantage plan, or Part C, as some people call it, you must be enrolled in both Parts A and Part B. To enroll in a standalone drug plan, you must be enrolled in either Part A and Plan B, Part B, or just Part A or just Part B. For your supplemental, you can contact the plan directly, or you can use an agent or broker. And again, we have spreadsheets about all the plans that are available here in Arizona. You must have Original Medicare, Parts A and B. Now, while you can buy a Medigap policy anytime they're willing to sell you one, we're going to talk about guaranteed issue in just a minute. But you may not purchase that Medigap policy if you are on access or are under 65. When we talk about this Medigap guaranteed issue, you cannot be denied or charged a higher premium for your health conditions if you apply within 6 months of your Part B start date, or your 65th birthday if you had already been receiving Medicare due to disability. So now note that if you didn't have any insurance coverage prior to getting this Medigap, they may make you wait 6 months before pre-existing conditions are covered. Many people, if they have already had some sort of serious health condition, which is ongoing, may really want to get this Medigap during this guaranteed issue, because they know that if an insurance company had the opportunity to turn them down for coverage, they would. So this guaranteed issue can be really important to a lot of people. There is also a guaranteed issue for a Medigap A, B, K, G, or L if you apply within 63 days of moving from an Advantage plan coverage area, or if your Advantage plan or Medigap was discontinued, or any kind of union, employer, retiree plan that was secondary to Medicare was discontinued. This is also an important time to talk about retiree health benefits. With some companies or even municipalities or states, if you don't take your retiree health benefits when they're first offered, or you disenroll, some plans will let you get back in, others do not. And this may also have an impact on family members if you still have them covered. So we really want you to understand that, to know whether you can get back in or can't, and also to know how those benefits compare to what you can get through Medicare. Not all retiree health benefits are the same. Some are great and are really cost effective, and people would want to take them if they're available to them. Others may still be quite expensive, and people might choose to go with Advantage plans or Medigaps and Part D plans. So you want to know that. You want to be able to compare the benefits as well as the cost. And generally, once someone is 65, most retiree plans insist that you take Medicare and they become secondary. Okay, delaying Medicare. What if you aren't ready to take your Medicare benefits? So here's something really important. If you are entitled to premium-free Part A, meaning you had your 40 credits, it's not going to cost you to have Part A. If you are eligible for free Part A, you may enroll with no penalty anytime during or after your initial enrollment period. Now, here's something which is a little tricky. So let's say I didn't enroll right at 65 in Part A. Let's say I enrolled at 66. My coverage for Part A will be retroactive up to 6 months from when I signed up, but no earlier than my 65th birthday. For most people, that's no big deal. But if I delayed enrolling in premium-free Part A because I was working somewhere where I had a health savings account, my contributions to a health savings account are not allowed if I am also enrolled in Medicare. So I need to be careful about when I sign up for Part A, in that I stop contributing to my HSA. Large employer groups that deal with this issue know about this and can help sort some of these details out. But if you have any questions about it, you could ask us as well. Now, if I would have to pay for Part A, then I would not want to delay it, because I would have a penalty, an additional 10% of that Part A premium every month, twice the number of years that I could have had Part A but didn't sign up. So very few people who would have to pay the premium for Part A are going to delay it. Though I should say, if someone is very low income, low enough that they may qualify for access, there may be ways for them to get their Part A benefits, whether or not they have Part A. And anyone who might be affected by that should definitely get in touch with us. Now, many people delay Part B, mostly because they are still working. The penalty for delaying Part B is an additional 10% of that Part B premium for each full 12 months that I could have had Part B and didn't enroll. And that penalty lasts for as long as I have Part B. But there is no penalty for delaying Part B if I have coverage through my or my spouse's current employer, if that employer group has at least 20 employees. If I am disabled and getting coverage through a family member's employer, then it has to be 100 people. But again, myself or spouse, I can delay Part B if it is employer-based coverage. VA coverage, COBRA, retiree group health, marketplace insurance, those do not exempt me from that penalty. The other thing about enrolling and having no penalty is that I need to enroll within my special enrollment period. And that is enrolling in Part B within 8 months after the loss of that coverage or current employment. Now, remember, most people try and do this so that if Medicare ends on March 31st, if their employer-based coverage ends on March 31st, they are set up for Medicare to start April 1st. And while you do have this 8 months to get the Part B coverage after the end of employer-based coverage, you only have 2 months to get into a Part D or an Advantage plan. If somebody missed their initial enrollment period and or their special enrollment periods, every January 1st through March 31st is what we call a general enrollment period. That's for people with needing Part B or who would have to pay a premium for Part A. And as of this year, the coverage will begin on the first of the following month after you sign up. But if you would be subject to late enrollment penalties, they will be applied. But if you are entitled to premium-free Part A, you can do that at any time with no late enrollment penalty. We are finding a number of people who have been on the marketplace as they come towards Medicare eligibility. And we would say that marketplace participants should transfer to Medicare when they first become eligible. The main reason for that is those subsidies which someone might be getting, and if you are eligible for premium-free Part A, whether you sign up or not. So what had been a really good price on the marketplace may not be when the subsidies go away. The only people, if they would have to pay a premium for Part A, they may be eligible to stay on the marketplace plan and get subsidies. And if you wait and don't sign up for Medicare on schedule, you might miss your initial eligibility date and have a penalty. Those marketplace plans are not automatically canceled. You want to notify the plan of your switch to Medicare, and you want to make sure that you know what to do for family members who may be on a plan with you. COBRA, which some people may be aware of from leaving a job, delaying Part B because you have COBRA does not exempt you from the Part B late enrollment penalty. COBRA is not a Medicare supplement. For people who are who have been getting treated with end-stage renal disease, they may be able to enroll in COBRA and keep Medicare. That's a little confusing. We would help someone if that's the situation. But keeping COBRA and not enrolling in Medicare may cause someone to have a large later enrollment penalty that will not go away. So when we talk about delaying Part D, the drug plan, an additional 1% of the current base beneficiary premium, which is currently $32.74 for every month for any continuous period of 63 days or more that you should have had Part D and didn't. I know that seems really complicated. The bigger thing to know is if you had other creditable coverage, and that might be from the VA or from an employer group, or even a retirement plan, if you had creditable coverage, and they are expected to let you know each year whether your coverage is considered creditable, then there would be no penalty if and when you choose to switch over to a Part D plan. Again, if you do it within 2 months of that creditable coverage ending. All right, so now you're enrolled. What do you do to make changes? So every year, October 15th through December 7th is the annual open enrollment period, and those changes become effective January 1st. You can change Advantage plans, you can change or add a standalone drug plan, and you can also switch between Original Medicare and Advantage plans. When we talk about the two sides of things, Original Medicare and Advantage plans, you can't be in both at the same time, but as you see, there are opportunities when people can make changes. There's also now a Medicare Advantage open enrollment from January 1st through March 31st. And this only applies to people who have been enrolled in an Advantage plan as of January 1st. So let's say someone's in an Advantage plan and it's January 2nd, and they discover that the doctor they really like is not in their network for that Advantage plan, but he or she is in a different Advantage plan. They could switch Advantage plans, or they could leave their Advantage plan to enroll in Original Medicare and get a standalone drug plan. They are not guaranteed, they do not have a guaranteed issue for that Medigap, but they might use that time before January 1st to see if they are going to be able to get a Medigap before switching back. There are also some special enrollment periods that individuals might take care of. If you move from your coverage area, that gives you the opportunity to take care to get into another plan right away in your new community. If you moved into or out of an assisted living or skilled nursing facility, again, you don't have to make a change, but you get that right to it as a special enrollment period. Same for if you've now been diagnosed with a chronic condition and there's a special needs plan. If your retiree plan is permanently ending, you would have a special enrollment period. If you wanted to enroll in a 5-star plan and there were some in your community, you could do that. We don't have any 5-star plans here in Pima County, so that's not an option. But if something happened and your plan was discontinued, that gives you a special enrollment period. For those who are lower income, those who have access as well as Medicare or any of the Medicare savings programs, that QIMBY, SLIMBY, and QI1, or who are getting the Part D extra help, they have a special enrollment period once per calendar quarter during the first 9 months of the year, and then the Medicare open enrollment period in the last quarter. To change Advantage plans, you just enroll in a different Advantage plan. To change or add a standalone drug plan, you enroll in that drug plan if you were already on Original Medicare. To leave Original Medicare for an Advantage plan, you just enroll in that Advantage plan. And to leave an Advantage plan for Original Medicare, you would enroll in a standalone drug plan, or you'd call Medicare to disenroll from your Advantage plan, or you'd file a signed and dated letter with the Advantage plan saying you wanted to disenroll. What you have to understand in a sense is there's automatic disenrollment. Enrolling in a standalone Part D plan disenrolls you from your Advantage plan. Enrolling in an Advantage plan disenrolls you from Original Medicare and your standalone Part D plan. The only exception being that Medicare Advantage MSA plan. People often ask us about switching Medigap plans. And again, if someone is in a guaranteed issue, they cannot be denied or charged a higher premium for health conditions. If they enroll, again, during that initial enrollment period, at that point, the insurance companies can't even ask you questions about your health conditions. Whereas later on, you are subject to health questions. You may have to pay more because of your age, and it's illegal for them to sell you a policy if you are on access. There are many people who, because of their health conditions, stay on that Medigap that they got during their initial enrollment period, and they never make a change because they know that no one else would insure them if given the choice. There are also 2 other guaranteed issue periods. So let's say someone joined an Advantage plan when they were first eligible for Medicare at 65. They get 1 year to try out that Advantage plan. If they don't like it, they could switch during that first year to Original Medicare, and they are guaranteed the right to get any Medigap policy sold in their area. Or if they started with Original Medicare and a Medigap policy, and then 1 year decide to switch to an Advantage plan for the first time, they have 1 year to try out that Advantage plan. But if they want to switch back to Original Medicare, they are only guaranteed the right to get their former Medigap plan back. Okay, paying for premiums. So if someone is receiving Social Security or Railroad Retirement Board retirement annuities, they will automatically deduct the Medicare premiums from those payments. Federal retirees can have the premiums withheld from their annuity payments. You can also authorize deductions from a bank account. You can make payments via credit card, bank check, bank draft, bill pay. They will send a quarterly notice, but if you are subject to the IRMA, they will send it monthly. So there are lots of ways that people can manage that. For the other things, the Medigap, the Plan C Advantage plans, or the D, you can set up to have those automatically deducted. You could authorize automatic deductions from a bank account, and I would say a lot of those companies like that. But some of them also will do credit card bank check. They may send you a coupon book or some sort of statement. I would say at this point, if you are not yet collecting Social Security and need to pay your Medicare premiums yourself, you need to stay on top of that, because they will kick you off of Medicare if you don't make your payments. And when you start taking Social Security, they start to taking it out of there. All right, so now let's talk about a few of the special things that people need to know about. Penny mentioned observation. This starts with a hospital emergency room. So several years ago, people were going into emergency rooms. They were seen and then released from the hospital, but sometimes having to be put into the hospital again soon afterwards. So insurance companies and Medicare kind of pushed hospitals to do more with observation. They are observing rather than bringing someone in as an inpatient. And it's kind of hard to tell the difference. The difference comes up in terms of how your costs are covered. If I am an inpatient in a hospital, then it goes under Part A, and that big deductible, which my Medigap may be paying, would cover me for those first 60 days. And I would have very few other costs for that hospital stay. Whereas if I am on observation status, then everything they do while observing me is going to go through as Part B claims. And so it's a little bit different. Another thing which may happen is that if I am admitted to the hospital, I might be able to receive medications that I need. Whereas if I'm on observation, I may need to use that hospital pharmacy and may have to submit claims to be reimbursed from my Part D plan. There is also an issue in hospitals. If I think that I am being discharged too soon, there is an organization called Levanta, which I can appeal to before I even leave the hospital. And all the discharge staff at the hospital know about this. There is also an advanced benefit, given an advanced beneficiary notice, which tells how to appeal decisions. If I am on observation, the hospital is expected to let me know that and let me know why I am not an inpatient. While I cannot appeal this decision, I can understand it a little better, and I can understand how this might affect me in terms of what the costs are going to be. I still have coverage because I have Part B, but it is not going to be exactly the same. The advanced beneficiary notice can come up with observation, but this can also come up in a doctor's office, in a lab, or with a durable medical equipment supplier. If I am asked to sign an ABN, advanced beneficiary notice, I can say, stop, I want to call Medicare and find out about it. But here's what the form will do. It will tell why Medicare may not pay and what my estimated costs would be if it didn't go through Medicare. And then I have three choices. One is to say, do it, bill Medicare, and I will decide to appeal if they will not cover it. Third choice is say, stop, I'm going to check with Medicare or with my doctor. But option 2 says, do it, but don't bill Medicare. And the only reason I imagine that someone might do this would be if I am told that the estimated cost, even without Medicare, is very low. I might decide to just pay it if they think that it is not going to be covered by Medicare. There are also a number of scams out there. One is Medicare calling. Medicare has over 56 million people. They don't make many calls. They send letters more often if they are trying to reach directly to you. There's also been scams about braces and other medical equipment, and the COVID testing and vaccines and genetic testing, as well as the eligibility for issues about home health care. So you want to be suspicious and be cautious about these kind of scams as they come up. We have information about Medicare marketing guidelines, how the plans can and cannot contact you, how they market their services. They are not to say that they are approved or endorsed by Medicare. They are not to market door to door, and they are not supposed to call you unsolicited. Though I can tell you, if you already have an insurance through a particular company and now you're aging into Medicare, they may contact you, but you don't have to respond to them if they do. We used to get a lot of scams about new Medicare cards. They are attempting to get your information and get your banking information. There are no new Medicare cards being processed. There's a lot of aggressive marketing, and that's what you see with the TV ads and the internet ads. And these are not even the agents. These are people who are working very hard to sign you up for something, and it may not be what's best for you. We like to say, don't get your information on Medicare from the TV, because it's likely to be aggressive marketing and not necessarily in your interests. You can also see the number of different postcards that get sent out. And here, this one is pushing about the Medicare Savings Program. But if you contacted them, chances are they're just going to try and sell you something. It is not official, and you want to always read the fine print. This was an ad that used to be on TV that said, have back pain on Medicare, call us. And then lots of small letters, lots of small words. And what it says is, I am aware of my rights to protect my privacy, and these rights are waived. I consent to receive information on products not limited to spinal support braces. If I am on a do not call list, I am waiving that right. The other thing is that these kinds of ads, you have to have, for the durable medical equipment, you have to have a doctor's order. You need to use an approved supplier to make sure of the proper fit. Medicare is only going to pay for a basic model. And if you get, let's say, a back brace from an internet ad, you might not qualify for new equipment for another 5 years, even though you're still having back pain. So again, check with us if you have any questions, but we would always tell you to use approved suppliers. And again, just some of the things that they send out, trying to get people to sign up. calls going to licensed insurance agents. Medicare sends out, or you can see them online, your Medicare summary notice, and the insurance companies have explanations of benefits. When you read your Medicare savings, your Medicare summary notices, you want to be sure you recognize the names of the doctors and other providers. Now, of course, if you had some sort of surgery, you might not recognize the name of the anesthesiologist or the radiologist, but you should recognize the dates, and they should match to appointment dates. Did you get the services that were listed? Does everything match up? And if you have any question about that, you can always contact us. We've gotten pretty good at sorting through what bills look like. Watch out for the Medicare fraud. It is estimated to account for 8 to 10% of Medicare spending. You can help by protecting your Medicare number. You don't give it to callers or someone who comes to the door. Medicare is not going to ask you for a fee or your personal information. By looking at those Medicare summary notice and explanation of benefits. Another reason to look at the Medicare summary notice is that if something was not covered, it will show that on the summary notice, and you might be receiving a bill from a doctor, and you only have a certain amount of time to appeal decisions if they deny claims. And then you want to report the fraud either to Medicare or to us here at PCOA. And help is available. As I mentioned, we have lots of spreadsheets. You can get those from us. We can answer all sorts of Medicare questions about enrolling, about billing, about comparing plans, about fraud prevention, and about those programs that help those with lower income. So again, call us or email us if you need more information, if you want any of those spreadsheets or the additional handouts, or just this has sparked more questions than it's answered, by all means, email us or call us. That's what we're here for. I also like to say some of this is really confusing, so go slow with it and call and ask us about the things that have confused you. This is what we do. So thank you for listening, and we hope to see you again sometime.
Thank you, Vicki. That concludes our presentation, and you have our number. If you need us, just give us a call or email us, and we'll be more than happy to walk you through anything that's confusing for you. Thank you, everyone.